4 right now has been a problem for years and usually unrecognized. So Shane?
Very true. Can you guys come up closer so I don't have to yell? Just a little closer. This way you can actually read things and I can actually talk to you about it. Where are you guys coming from? What specialty area? Beats. Okay, well.
Sorry.
This may or may not really kind of affect you. Since we only have one resident from our staff here, this will be geared towards you, Rachel, so I have to pay attention to some of these things. So we're talking about blunt cerebrovascular injuries. Again, it's something from our standpoint, you're not going to see very much of, but you have to look out for it because consequences are pretty great. So again, why do we really care? So the incidence that at least in the literature talks about 1 to 2% of all blunt trauma. Although that number is going to be skewed because in the past we didn't really look for it. Now we're doing more to look for things, and the criteria for risk is expanded. So that number could change to a bit higher. It's probably never going to exceed 5%, but it's still going to be significant. Again, we didn't really start initiating kind of screening until about 20 years ago, and those were really kind of very narrowed criteria and has since expanded. And again, you see the incidence of blunt trauma between really 1 and 2%. This was again before a lot of screening has changed. Denver is the one who has published the most about blunt trauma, or at least this incident, and their old literature is about 1.5%. Now they've changed their screening criteria. It's actually increased to about 3 to 3.5%. And again, current screening guidelines. When I say current, that was like more than 10 years ago. We'll talk about what the difference is now compared to then.
But I think one of the points just for the P's, with the current interest in chronic traumatic encephalopathy that doesn't require even a single loss of consciousness to develop the same sort of plaque deposits you see in Parkinson's, Alzheimer's, and whatnot, they're beginning to think that it actually may be, the subclinical blunt head injury may, at an early age, may be equivalent to a devastating head injury at some old part my age. And so this is actually remarkably germane to kids. And then the question of, should we be allowing children to play contact sports, and if so, at what age? But I think this is really very important for.
Interesting, but a lot of the data doesn't pertain to the kids. There's not a lot going for them, so how it plays into contact sports like that, hard to say from the data standpoint. But again, why is it important? Because stroke rates are pretty high. It goes unrecognized. Again, stroke care is pretty expensive, even for the direct costs. We're talking about $100,000 per patient. Doesn't factor the cost of indirect costs, like rehabilitation, loss of productivity, lifestyle changes, things like that. So it is important. It's small in the numbers that we see, but it's important in terms of the clinical outcome. Again, the majority happen within hours. So that represents a therapeutic window that we, as a trauma team or as a care team, can actually intervene on. Again, you can see carotid artery injuries, all comers, pretty high, 50% roughly. And again, the cerebral arteries a little bit less than that, but can be pretty high depending on the type of injury you see. Again, CVA risk. So we'll talk a little bit about what the different classifications are. Again, once you even minimal injuries, still pose a threat for stroke. And again, this is what represents an area that we can actually intervene on. But again, the higher the grade, the higher the risk of having a stroke. You can see, even just for grade 2s, which I'll explain a little bit later what that is, you saw a pretty significant stroke rate. So even for carotids, 14 versus 38 for vertebrals. So again, even kind of what seem to be minor injuries can have catastrophic results. Again, mechanism, here's kind of a classification by Christie and Bernstein. 3 different classifications. One is a direct blow to the neck. The other one is the most common one, which is kind of a hyperextension rotation component to it. That's probably the vast majority of injuries that we're going to see, or a direct laceration from a fracture. Those are the minority, but again, number 2 is one that we're going to see most often in our population. Okay, so this is just kind of a global thing that was done out of Memphis. They looked at their data for the past 30 years, pre-institutionalized criteria versus what they've done since then. And as you kind of see, over time, 10 years, gets what's smaller in the window, so they have 5 different time periods. You look up here, and you kind of see the numbers of diagnosing blunt injuries has steadily increased over time. Not only that, but the incidence of injuries has steadily increased over time. Again, that's the modification of the criteria and started looking for this actual disease process. One thing I want you to kind of keep an eye on, this line right here says patients treated with stents. Kind of see there was kind of a peak area in the mid to late 2000s, and it kind of dropped off. We'll talk a little bit about why that is. But again, most important part of this slide is really this chart right here. We can kind of see from the early parts, you can kind of see the stroke rates, mortality is pretty high. So they weren't looking for it. They didn't recognize it. They understand it. And as things went on, this is when they started putting the protocols in, getting screening criteria, saying these people need to be looked for. And you kind of see the stroke rates and mortality steadily has decreased over time. So the things that we're doing are actually making a difference. You can see we're actually minimizing, or essentially minimizing the effects of having that particular injury. All right, so these are two main guidelines. This is EAST from 2010, and then WTA, or Western Trauma, 2009. So in terms of, from a clinical decision making, this is kind of ancient, because a lot of things have changed since then. But since these are what's still published guidelines, we'll talk about this and talk about what's changed since this publication. And again, these are the two main authorities of what we kind of do, what the community kind of looks at of what we do in terms of our practice. All right, so this is 2009, this is WTA. On this side, Western, this is EAST over here. You kind of see EAST is very nebulous. They didn't have a whole lot in terms of information, but again, everything is level 3 data. And it's just kind of really recommendations and sort of case studies. The same thing over here. This one's a little more comprehensive. This is kind of what's been used, and although this has changed, but this is what's in 2009. Biggest thing here is understand this part right here, about different CTs, and this part over here, the risk factors. These are what's really going to change. So patients with high energy mechanisms, again, that's like rotational components with the hyperextension, mid-phase fractures, 2s and 3s, reports, phase 4 skull fractures involving the carotid canal, closed head injury consistent with the DAI or GCS less than 6, and then cerebral body fractures or involving the canal or the foramen, and then near hanging closed eye injury. Those are going to change. Just kind of keep an eye on that part for this section, and then you'll see how they expanded over time. So again, this is from Denver. The guys published a significant amount of literature on this. And so what they did in 2011, published a paper looking at that particular criteria, going, how are we doing with this? So they identified a significant number of patients over, you can kind of see here, over about 13 years, 14 years. What they found was, with their screening criteria, they were identifying about 80% of all injuries, or 20% that were missed. So what they looked at said, what were we missing? What injury patterns can we incorporate into our algorithm and say, we're not going to miss anything anymore? So over here, these are the ones that they identified. So again, mandibular fracture was pretty significant in terms of the asymptomatic patients, along with skull fractures, and again, people have thoracic injuries. So these are going to influence of what's been changed, although it has not really been adopted yet into the WTA guidelines. It's just what's been proposed. So this is what they've changed. This is, again, 2011. Add the ones in red are what they changed to the screening criteria. I don't know if you can see it there. If you can't, just scoot up. So mandibular fracture, skull fractures. Any basal or skull fracture. We're in complex skull fractures, which are important. Again, TBI thoracic injuries, scalp degloving, thoracic vascular injuries, but again, upper rib fractures. That has not really been defined what that means. Is it ribs 1 and 2, just one by itself, down to 3, down to 4? It hasn't really been defined. So again, you got to take this high energy transfer mechanism, include that with the upper rib fractures. So that may mean somebody comes in with a rib fracture of 2 and 3 that was in a high-speed crash, they might need to be included into that risk criteria. There's a lot of openness in terms of discussion about what to do with that. So again, before they said 16 slice, now it's a multi-slice. Right, so they said anything less than 8 is not adequate. That was in the previous guidelines. But as we'll see, even 16 and 32s aren't necessarily that great. So then the newer guidelines talk about 16, 64 and above. Well, we don't have above 64, not yet. But again, they kind of changed some of their treatment, what to talk about, and some of the other things. But the big thing here is just to realize the difference in the screening criteria, how it's expanded. And so, what did they do with that? Put a paper out. This was just a couple of years ago. And so what they did was they looked at the data from 2015 to 2011 with this expanded criteria that they used at their institution and said, did we make a difference? All right. Okay. So what happened was, over time, you're gonna see, here's the classic, that was that one we just looked at before, and the expanded criteria, you gotta see they started making an increase in their diagnosis. So they had asymptomatic, all levels, not only ones and twos, but even some threes and fours. So they're missing, or they're capturing significant injuries they otherwise would have missed. And again, if you take out the classic expansion down in this part here, it's just the expanded part, you kind of see they found a significant number of patients that they otherwise would have missed. So based on their data, they would have captured 95% of those patients in that previous study that would have potentially been missed. Okay, so again, that expansion is what captured more of their patient population. Does that make sense? Okay. So again, now this is the new. This is the 2016 that they put out. This is their guidelines they use in Denver. Hasn't been made over to the WTA or East yet. When they put their guidelines, it probably will. So again, you kind of see the expansion of the risk factors. Again, the upper rib fractures. I want you guys, especially our residents, to look at and understand what that is. There's potentially a screening protocol for them. Again, multi-slice, they recommend, again, 64 channel, which most places have that when we do, so it's not much of an issue for us. But again, some places still use a 32 and a 16. And we'll talk a little bit about what that means also. So again, expanded criteria, capturing the majority of patients that we would otherwise potentially miss. Any questions about the risk screening criteria? All right. So again, imaging. So previous guidelines about 16 and above, 32, 64. What is really going to be the optimal modality to identify these injuries? Again, DSA or digital subtraction angiography was the gold standard, still is, but it's not really feasible to do that on all these patients. A lot of times, I'd say a lot of times, but Memphis Group is one that's kind of been really resistant to change. They still do a lot of DSAs, so a lot of data is going to come from them just because they continue to do it. Again, how accurate is the CTA? Even though the algorithm says use the CTA, really how good is it? Even the 64s may not be as great as they might think. So we'll talk about a little bit about that. Again, is the high risk of false negatives, they can be offset by the inconsequential outcomes. So you're going to see the majority of injuries that are missed with CTA are going to be grade 1 injuries, and you'll see some data that may not necessarily mean anything if you miss it. Most people will go on will have won't have an untoward outcome, and it won't mean anything. So again, if we exclude type 1 injuries, there's a sensitivity to get better. Again, number of slices, and the data right now is currently really conflicting about what is an optimal modality. Again, east over here, west over here, again, 16 slices, that was 2009, this is 2010. As you can see, level 3, this multi-slice 8 or greater. Is that actually adequate or not? Not a lot of data, they kind of threw it in there just based on what they had at the time. All right, so this is from Richmond, kind of the mid-2000s, talking about using a CTA. This is a 16 slice. What they found over here, normal on the CTA, all these people got CTAs plus a DSA, and they found that there were a significant number of false negatives. So negative on CTA, angiography found that there were actually injuries. They didn't talk about really what that meant, that those injuries led to any kind of adverse outcomes. But you're going to see that the CTA and these results as the 16 slides are not as great as it could be. Another paper talking about 16 slice, but they found kind of the opposite based on their data. Small numbers, but they're talking about a sensitivity and specificity that's pretty good based on their data. This is a 16 slice. So it's kind of conflicting data what that means. And that's kind of what we come across here. 32 slices is out of Memphis. They did the same thing. Everybody got CTA followed by a DSA. And so you kind of see here, their sensitivities for it are in the 50s. So you're kind of just flipping a coin basically for that. So basically on there,
Do you know, and I apologize, my original comments were about blunt cerebral injury as opposed to cerebrovascular injury, so I apologize for that. But do you know what type of CT scanner in the, never mind.
the 32?
Read the damn
Okay.
slide, yeah.
So is it Siemens? I have to go back and look and see if it's who made it, but yeah, 32.
Yeah.
So this was when Memphis people were saying still angiography is the gold standard. What's that?
Spot ass.
But again, so their outcomes were again not good enough. So they were not at this time. We're not saying let's use a CTA. They're still recommending DSA. But of course, things change over time. So this is a 2014 paper, same group, same kind of setup. People got CTA announced at 64 versus the DSA. All right, so now they come out and go, oh, it's a little bit better sensitivity-wise. But what was discussed at one of the trauma conferences is the ones that were missed were type 1 injuries, which actually did not have any kind of untoward effect. Those are ones that may be inconsequential, so if you exclude those, the sensitivity may go higher. So that's when they kind of said, you know what, it does make it better. So this is the last group that kind of said, all right, we can get rid of the DSA and go with CTA. So it's kind of, that was the last paper that said CTA is good enough to do what we want to do. Okay, and then the next thing, well, you have 128, and then you might have what you want from that standpoint. But 64 seems to be okay from that standpoint. Okay, and again, if you look down here, sensitivity 16 to 64 going up, still not that great based on this group. I think this is out of Ohio, but specificity has always been really good. All right, so if an injury is seen, then you can trust it. What's not seen, maybe not. And this was just a meta-analysis just a couple of years ago. Again, looking at different papers. Specificity is always pretty good. Sensitivities are not that great. But the thing that's interesting here is the interpretation. So we've got a neuroradiologist. Sensitivity goes up higher than if it was a non-neuroradiologist. So again, interpretation is going to be the important part. So if somebody's reading this and they don't read CTAs very much, sensitivities or even specificity is going to be lower than it would be if somebody who actually reads them and understands what it is. That's the important part of understanding the CTA data is who's reading the actual scans. Okay, so again, sensitivities are okay, but not that great. So the answer is, well, not the answer, but the question is, what about a whole body CT? This kind of goes into, someone comes in, a trauma patient, is getting a CT for other things, go through the neck. They just all get it. And then from there, you select out people who potentially have injuries and do a formal CTA of the neck. So is that something that's possible? Maybe. These are people out of Baltimore at Shock Trauma who kind of did that. So which is anybody who's going to get a CT of the neck or head or the chest, let's just go ahead and throw in some neck stuff too. It's not a formal CTA, but they ran contrast through the neck to see if there's any interest. And so what they found was they identified patients who otherwise would not have met screening criteria. They identified injuries. So this could potentially be something because most people get scanned head, neck, and or C-spine, I should say, and chest. That if you add a little contrast to it, it's not much more in terms of time, it's not much more in terms of radiation, that you might actually identify people who otherwise would have been missed. But again, this is just kind of retrospective data, just kind of seeing what would happen. Possibly, it just kind of raises the question, maybe that's something that could be down the line. Okay, so the other thing was repeat imaging. You gotta see here, they say repeats in 7 to 10 days, everybody who gets injured. But do we really need to do that? That's the question. So again, from the same people who wrote that actual algorithm, they're saying actually no, you don't really need to do a repeat in 7 to 10 days. The question is why? Why would you even make that recommendation when it shows that you don't need to? So the data right here shows the majority of type 1 injuries either heal or they don't progress after 10 days. No change. Same with vertebral arteries. Most heal, the other parts don't really progress, although there are some that do. And then higher grade injuries, 2 through 5, or actually 4, that they don't really heal within 10 days, but they also don't really progress all that much. Sometimes they do, but not so much. So does 10 days really offer you anything new? Can it change what you're going to do? The question is, well, I don't know. Do we go 30 days? Do we do 45 days? Do we do 60 days? So no one really knows the answer to that question. But it's posed because 10 days seems not to be of any kind of thing. So that's something that could potentially change in the future. It just hasn't been really looked at from a data standpoint. All right, grades of injury is for you guys. Okay, so again, grade 1 is 25% or less. Grade 2 is over 25%. That's all you really need to know for those. Grade 3 is a pseudoaneurysm. Grade 4 is a visual occlusion, and grade 5 is the actual transection. Okay, so management is going to the grade's going to kind of determine management. If you look at the algorithm, it said anything from 2 to 5 was an operation if it was surgically accessible, or potentially stent, or anticoagulation. But their guidelines were do an operation. You see, the majority of these will be okay without any intervention, with just other than antithrombotics. So again, grades here, some pictures. So again, treatment from their guidelines, 2 to 4, surgically accessible, yes, operate. Do we really need to operate on this? So if you have a 2, then you just get away with antithrombotics. That's probably the answer. It just hasn't really been studied all that well, I should say. So these guidelines, again, really nothing. Just you need to use heparin, use antiplatelets, just kind of use something at the beginning, and then how long you use it for, don't really know. Do they need 3 months, 6 months, 9 months, a year? Don't really know. Just don't really follow it out long enough. What happens if they use a stent? Do they need to use anticoagulation for how long after that stent's been used? Depending on the stent, I guess. But it really hasn't been used very well. So the current recommendations, somebody in a hospital who has been diagnosed with an injury that is to use heparin. 15 units per kilogram per hour with no bolus that titrates to 40 to 50 your PTT. So why do you think that is? Why would you want to use heparin? Yeah, exactly. So a trauma patient, most patients are going to have more than one injury. And if something happens, you need something to quick on, quick off, and you can reverse. So antiplatelet therapy is just as good. It's just if you use it, you're kind of stuck. All right. So again, protocol less than 1%, transition to antithrombotics after the initial portion. So you can get through their injury, then you can switch over. What that is, antiplatelet versus antiplatelets, no one really knows. So you put on aspirin, they need to go on something longer like Coumadin or one of the 10A inhibitors or 2A inhibitors. Don't really know the answer to that question.
Just from a basic science standpoint, just recognize that typical, if it comes up on an exam or relevant physiology is that if you're dealing with a high shear force, high flow velocities, then typically you target platelets. If you're dealing with low flow velocities, you use factor inhibitors. And so for most stents, they're going to want to have something that's going to inhibit platelets, because simply inhibiting the factors, unless you get really aggressive, is not necessarily adequate. And it's just the basic science of clot formation is different in the venous and the arterial systems.
So using that protocol, they decreased their stroke rates in St. Memphis and Denver significantly. You kind of see it's pretty profound. But again, no prospective randomized data. It's all kind of just case reports. This is what we do. This is what we're reporting. So again, the optimal regimen remains to be seen, or it's unanswered. But again, if you see from this is again the Denver group talking about their history of patient-wise. If you look at using heparin, aspirin, or aspirin Plavix, you kind of see their stroke rates are pretty low. Doesn't matter which they used something, and it seems to improve it versus the patients who didn't get anything. Who were contraindicated or subtherapeutic, you kind of see their stroke rates were a lot higher. So that's again, what's the optimal regimen? Don't know. Just use something. That seems like. Again, over here, same thing. healing, non-healing versus using nothing, much better outcomes with that. Stent-wise, so if you guys saw that one of those early slides with Memphis guys, they're using stents in the early or mid-2000s, they're using a lot of them, and then it dropped off significantly. Well, why? Why do we need to use stents? Does it make a difference? And you saw some of the other data saying it didn't really matter. If you put them on the anticoagulants, they did well. So again, out of Memphis, because they're the ones that did a lot of stenting, they looked at their data. Again, patients, angiography, cardiac vertebral. As you're going to see in the vascular medical, really not a whole lot in terms of the outcome differences. Now, that's going to be skewed because it's going to be a bias. So certain people got the stent because of a certain reason versus medical-wise. But it doesn't appear that stents offer anything in terms of a better outcome depending on the injury itself. Now, again, a lot of these were type 5s were excluded because those are going to be a different category. But when 1 through 4, it seems medical management is probably appropriate. That's why the stents have kind of fallen out. If you had all the other data from other places, their stent usages have dropped significantly since the mid-2000s. So it appears that stents don't offer any benefit. The other exception would be potentially if you have a type 3, which is a pseudoaneurysm that is enlarging or becoming an issue. That's where it may benefit. Okay, again, Denver group, same thing. Patients with blunt injuries, looking at stents versus non-stents on the thrombotic stent usage, it's actually gone down. You kind of see from 2000 number of stents. Afterwards, not much, again, because of outcomes of the data. There was really no benefit that which they can show from using stent versus anticoagulation. Okay. All right. So the other question is, somebody comes in and they have multiple injuries. So how do you treat that person? All right, so if you're going to be kind of contraindicated to using any kind of antithrombotics, so what do we do? Or when do you start somebody on something? So if somebody has a head injury that has blood in the head or has a solid organ injury, when can you actually start using the therapeutic, either antiplatelets or the heparin? So this paper just came out recently talking about what do we do with these patients. This is 2018, last month, from, I think it was Houston, published this data. So again, you kind of see this 300 patients, majority of them were multisystem trauma. So they had other things that were going on. So they did, stroke rates were really no difference between the two, even from a delayed standpoint, but they all were treated eventually. Meaning, if you look over here from the time the diagnosis of the treatment, from the isolated group was within 20 hours, versus multi-system group was within 54 hours. So it kind of falls in line with some of the current guidelines in terms of when you start your DVT prophylaxis on somebody with a head injury or solid organ injury, about 24 hours after a stable CT or stable hemodynamics. So it kind of falls in that line. That's when you would start the DVT prophylaxis in that area. Again, time from injury to treatment almost doubled in the multi-system injury, but there were no differences in their stroke rates. So you have a little bit of time, but don't wait for 3, 5, 7, 8 days. So you can do it within 48 to 72 hours in years. But again, this isn't randomized data. This is just something they kind of said, this is what we did, this is what happened. So it appears that that's okay. So it's coming in, multiple injuries, within 48 to 72 hours, it appears that it's safe to start them on their therapy. Again, and they reported no increase in bleeding complications, no increase in progression to spinal cord injuries, or even progression of intracranial hemorrhage. So, and this is, again, not just the DVT prophylaxis, this is actual therapeutic. We're actually increasing your PTT. So, again, no increased incidence of bleeding or complications. Okay, so again, conclusion-wise, screening criteria has made a big difference in terms of the outcomes of a lot of these patients. So it keeps expanding. So we don't know what the exact criteria is going to be, but based on the Denver data, what they produced has actually been pretty good. 95% of those patients are going to be identified. There's going to be an outlier. Some of their data is a patient that had a pelvic fracture who had a blunt cerebrovascular injury that would not have been picked up. It's probably not going to be picked up regardless. There's actually people in their data who didn't have really any injuries, but still had a stroke from an injury. Those people are going to be outside those guidelines also. So it's not going to be 0, but if you get 95%, it's pretty good. CTA is good, but it's not great. So it's still pretty good. Hopefully, as technology improves, that number will go up also. And then again, DSA is not feasible, especially if you're expanding your criteria in terms of your risk. You can't, this is too many things going on in order to make that a feasible thing. So again, a whole body CT, we'll have to wait and kind of see what goes with that, if that catches on, if there's any kind of new data that goes with that. Short-term repeat imaging is probably not necessary, so that's 7 to 10 days, you can probably scoot that off of your algorithm, but we don't know what the optimal follow-up time is. They probably need something, especially if they have a greater than a type 2 or type 1 injury, to kind of see if there's any progression or actually healing. Again, anticoagulation, it's really a dealer's choice what you want to do, just something, basically. And again, routine stents, probably not necessary, but there's going to be isolated cases, going to be case-by-case basis, but there's going to be room for it, but not kind of a routine practice. Again, things to consider about these patients, multisystem trauma, they're not going to be able to be anticoagulated at certain times, but again, don't be too shy from it. Kind of have to be kind of aggressive with it, but again, don't put the patient at peril. Delayed imaging, this is something that we see as a tertiary referral center. Patients who have been injured outside hospitals, all of a sudden they show up hours after their injury. How do we deal with that? What's the important part of that? We don't really know. Again, duration of antiplatelet therapy or anticoagulation outside of that window. Is it 3 months, 6 months, 9 months? Really don't know. That's going to be kind of a case basis also. Again, if stents are used, how long are we going to be using those antiplatelet therapy or even antithrombotic therapy? Again, long-term outcomes with patients with stents. Don't really know what that is. These patients tend to be younger than your typical vascular paths, by about 20 to 30 years. So what happens over that time period, really don't know. Even people who need to go in and get a graft put in from a surgical, you don't really know what happens 30, 40, 50 years down the line. There's really going to be any consequence to that. But again, if you don't do anything, we already know what the consequence is. So those are kind of just questions that kind of remain that aren't really answered, and it's just kind of can't really extrapolate that from the vascular data because it's a completely different animal from the patient population. And then questions. Yes?
So that's actually pretty relevant. We have a patient on the floor right now who with a skateboard injury, subarachnoid hemorrhage, partial thrombus on node.CPA of his right from jugular right at the skull base. Neurosurgery recommended hold anticoagulation for 5 days. Today's the 5th day, and they wanted to bridge the community. Because of his age, and I thought it'd be, with his lifestyle, it'd be easier to do one of the novel new anticoagulants. Would you have any recommendations on Coumadin versus like a Xarelto or anything like that?
Well, there is no data to use it to say, well, we won't know this. I personally hate Coumadin just because it's difficult to manage, but there's nothing that says that anti-10s will actually improve outcome with this patient. So he has a thrombus of the
Partial thrombus.
So that's a different animal than what we're talking about, because this is carotid. This is an artery versus a vein. But the question is, what kind of fracture did he have around that area? I'm not sure why he would have a thrombus in there isolated, but that's going to be something different. So